Laura Magee, who's a professor with us at King's College in the Women and Children's Department here, is able to share some of their fantastic work related to term preeclampsia. Laura, I have to say I'm delighted to focus on this area. You know, we were all told when people were doing low-dose aspirin that only early preeclampsia seems to matter, but I think all preeclampsia matters. So I think having a focus across the whole spectrum has been an area that I'm delighted that you're focusing on. So we're looking forward to hearing what you have to say about this. Thank you.
Thank you very much, Andy. And I'm really appreciate the opportunity to talk about the Prevent Preeclampsia or Prevent PE research agenda. And I do so today on behalf of the whole team, clinical, health economic, social science, and we should have time for questions, but if there are any others, my email address is there and I'm happy to receive any by email. So I have no relevant disclosures. Now, we know that timed birth is an important intervention in the management of preeclampsia across the spectrum of gestational age. But with Prevent PE and with some of the background information, the ARRIVE trial and the WILL trial, we now have evidence that preeclampsia or risk stratified timed birth at term can reduce the incidence of term preeclampsia, which of course represents the vast majority of the disease, as Andy has already emphasized. Now, as background work for Prevent PE, we looked at a stratification of preeclampsia risk at 36 weeks to try to model whether a risk stratified timing of birth intervention might be worthwhile. And so you can see here on the left in the hot pink box, 1.6% of the population at 35 to 36 weeks is at very high risk of preeclampsia, at least a 1 in 2 risk. And then we have high risk, intermediate risk, etc. Over to the right-hand side, also in hot pink, very low risk, so a risk of under 1 in 50. And we modeled that if we assigned a timed initiation of birth to each of these risk boxes, could we reduce the incidence of preeclampsia? And we thought that we might be able to do so by 50%, but we would need a trial of 8,000 women to have 90% power for a primary outcome of delivery with preeclampsia. And I just wanted to say this is an image from that background paper, and just focus your attention over here on the right. So the bar that goes below the horizontal line is the up to 50% reduction in preeclampsia. And then the bars that go above the line are the proportion of the population who would require planned birth at the gestational age. And you'll see actually that the highest bar is at 39 weeks, and then the next highest at 40 weeks. So that's when most of the timed birth would be occurring. And we calculated that the number needed to deliver, to prevent one case of subsequent preeclampsia would be 8.4. So that all seemed good. So we embarked on the Prevent PE trial funded by the Fetal Medicine Foundation with materials for the angiogenic marker measurement, because 35 to 36 week PE risk classification requires S-FLIT and PLGF, in addition to the history and the mean arterial pressure. And I've just put up the health value compass here, and I'll work my way around it. The clinical outcomes for Prevent PE were presented by James Goadsby last year at the APEC meeting, but I'll just remind you of what those findings were. So we approached almost 11,000 eligible women who were attending a routine 36-week scan. The scan wasn't necessary for the risk assessment, but it was used as a recruitment opportunity. 75% of women said yes, they were keen on this personalized approach. So just over 8,000 underwent randomization, just over 4,000 in each group, with a small number who withdrew consent who were randomized in error. So again, just over 4,000 included in the analysis of the maternal and the perinatal outcomes. In terms of the risk strata, the color-coded picture that I showed you before, the proportions in each of those boxes was very similar to our modeling exercise. And you can see here that the lowest risk group, so the less than 1 in 51, was 78%. So that means there's a 22% screen positive rate, and they were offered risk stratified timed birth. So our primary outcome of birth with preeclampsia subsequent to the 35 to 36 week screening was significantly reduced by the risk stratified timing of birth, 3.9% in the screen and timed birth group, our intervention group, versus 5.6% in the usual care. This represents a 30% reduction in preeclampsia. Adherence was high, 83%, and the number needed to treat in the trial was 13, lucky 13, to screen for preeclampsia and be offered risk stratified timing of birth. Now, of importance, we had 2 key secondary outcomes, neither of which differed between the groups: emergency cesarean and neonatal unit admission for at least 48 hours. I wanted just to point out a few important details. You'll see at the top here that the preeclampsia, which was defined by the ISSHP 2021 definition, was reduced based on the antenatal onset. So we didn't just shift the preeclampsia onset into postpartum. 2, that the components of the ISSHP definition, proteinuria, maternal organ dysfunction, and uteroplacental dysfunction, showed the same pattern of reduction, numerically lower, in the screening versus the usual care group, and that the floodgates for induction of labor didn't open. They were very similar in both groups, so 24.9% in the intervention and 23.8% in the control. I'd also like to emphasize that the perinatal outcomes were no different. So whether we looked at perinatal mortality, whether we looked at small for gestational age, regardless of its definition, or neonatal morbidity, with no significant difference between the groups. And just highlight that respiratory distress syndrome, excuse me, also showed the same pattern. Now, of course, when we're looking to evaluate an intervention, we need more than the clinical outcomes. Another component that we need is cost. So the health economic evaluation was also led by the KCL team, with Julia Fox-Rushby as the senior health economist. And there were 2 components of this. Excuse me, a short-term analysis within trial and an intermediate term analysis modeling. So the short term looked at the incremental cost per preeclampsia case averted, so cost effectiveness analysis from the NHS perspective. The costs, excuse me, captured were screening and health service utilization for the mother from 35 to 36 weeks to discharge, and for the babies, health service utilization until discharge or 28 days after birth, whichever was earlier. And I should note that the cost of the ultrasound was included in the cost of the intervention, even though it was just a recruitment opportunity. The intermediate term analysis, the modeling, looked at incremental cost per quality adjusted life year gained. So, excuse me, a cost utility analysis. And the costs captured were for the implications of preeclampsia related complications for the mother and baby. We didn't look at long-term cardiovascular modeling because most of the evidence suggests that the lion's share of the association between preeclampsia and long-term cardiovascular diseases related to shared underlying risk factors, which of course were not changing by timed birth. So in the within-trial analysis, the PREVENT-PE intervention versus usual care resulted in an incremental cost per case averted of 75p, which our team has described as less than a latte, way less than a latte. And this is up to 28 days postpartum. And then in the model-based results, the intervention may be dominant with lower costs and slightly higher effectiveness for the first postpartum year. And at a willingness to pay a standard threshold of 20 to 30,000 per QALY, the probability of the intervention being cost effective is extremely high, at least 95%. So our interpretation was that preeclampsia or stratified timed birth at term versus usual care is a cost-effective intervention up to 1 year postpartum from the NHS perspective. Super. Now we have other points on the health value compass that we need to address. So well-being and satisfaction. And so there's been quite a strong social science component to the Prevent PE research agenda. So now this was added on after the trial began. So by the time it went through ethics, we were conducting this part of the research from March to October 2024. This consisted of an online survey consisting of validated scales and non-validated items adapted from the relevant literature. So how the trial was communicated to the potential participants, acceptability of the intervention, the psychological impact of the risk stratification, and then in the postpartum survey specifically, because there were antenatal and postnatal surveys, anxiety and the birth experience. And then the participants were sampled and underwent semi-structured interviews, and we accounted for diversity, patient characteristics, impact of the trial, and antenatal and postnatal participants. And the topics covered were very broad. They ranged from the beginning of the pregnancy, experiences of maternity care, right through to experiences of the intervention and postnatal experiences. So I'd like to tell you about 3 analyses. The first is a quantitative analysis of women's perspectives on acceptability and risk communication. This is currently under review. The included in this analysis were those who consented, confirmed trial participation status. So they had to, their records weren't otherwise linked, so we relied on them to tell us, and completed acceptability or risk communication measures. And of those assessing this, accessing the survey, 48% antenatal and 30% postnatal respondents were eligible. The respondents were similar to the trial participants overall, although vastly lower in number. And then antenatally and by trial arm, and this is the theme of these findings, most women felt comfortable with the trial, that participation required little or no effort. They were confident in their participation, the trial was acceptable, and preeclampsia risk screening they felt was fair, could reduce the chances of becoming seriously ill, and they understood how that could be achieved. So very positive. Also antenatally and by trial arm, about half of the women disagreed that this timed birth for preeclampsia intervention would interfere with competing priorities, although 20 to 30% did feel that there would be some interference. Antenatally and by trial arm, the vast majority of participants, they felt listened to, able to ask questions and have helpful answers, that their preferences were considered, they were clear on the situation being discussed and confident about their decision. And finally, just over half of the women were uncertain about what was going to happen. So this is in both arms and antenatally, so reflecting the general pregnancy experiences. And then postnatally and by trial arm, the views were more neutral, but there wasn't an increase in negativity. And recall, for some of these patients, quite a lot of time had passed from the beginning of the trial. And so findings indicate that women find 3rd trimester screening for preeclampsia and risk stratified planned early term birth highly acceptable. They understood their risks and the potential to favorably impact their pregnancy outcome. Now, we also included health professionals in this social science agenda. So I'd like to tell you about a mixed methods study using survey and interview methods, and this is also under review, because we know actually very little about how healthcare professionals perceive the acceptability of 3rd trimester preeclampsia risk screening. So similar to the women, the staff were invited to an online survey comprising validated metrics of acceptability, And then they were analyzed descriptively. And then staff were invited to one-to-one interviews. And using template analysis, the responses were mapped onto the following domains of acceptability. So sense-making, commitment, change, communication, motivation, action, and evaluation. There were 65 completed surveys and 19 interviews. The ratio of staff from King's, 41, and Medway, Maritime Hospital, where Prevent PE was conducted, were similar, in line with recruitment. Almost 30% of the staff were of non-white ethnicity. Most were doctors or midwives, and about a third had no prior involvement in clinical trials. And the acceptability was endorsed by the majority of survey respondents. The interview findings endorsed acceptability for most staff towards participating in an evidence-based trial. And despite some concerns about implementation burden, system-level readiness, and counseling high-risk patients, which takes time, staff supported integrating such screening into routine maternity care if effectiveness were confirmed by the trial results, which now we know was confirmed. And I should say that the clash was evident in our findings between the traditional midwifery preference for non-interventional care, excuse me, and obstetricians' willingness to intervene in timing of birth to minimize adverse outcomes. So what we concluded was that Prevent PE had a high level of acceptability amongst healthcare professionals, and staff used screening with the potential to positively impact outcomes. And finally, we looked at women's maternity and birth experiences qualitatively through semi-structured interviews with those who were screened and had a time birth, those who were randomized to usual care, and those who declined randomization. And the analysis was through template analysis. And there were 4 key themes: achieving efficiencies with research-embedded clinical care, communicating trial information, building relationships with care providers, agency and shared decision-making. And I think that we've alluded to almost all of this so far this morning. Maternity service delivery was deemed efficient, as was care received during the trial. But there was a volume of complex medical information that caused concern. I think all of us are concerned about this with patient information forms. But regular, consistent contact between women and their healthcare providers helped women feel valued and understood, especially when they were provided with the opportunity to ask questions and have them answered. So we concluded that participation within maternity should embed the principles, I think we'd all agree, of effective communication, relational care, shared decision-making, and efficient service delivery to enhance maternal experience and improve outcomes. So we know that time birth is an important intervention in the management of preeclampsia across the spectrum of gestational age. We now have evidence that preeclampsia risk-stratified timed birth at term can reduce the risk of term preeclampsia, which represents the majority of the disease. This approach is cost-effective and it's acceptable to women and staff. But can we do better? And so if we look at the diagram I showed you earlier with the risk strata, and this time the little percentages on the top represent the results from Prevent PE. What we saw when we looked by strata for the 37 and the 38 week, the very highest risk women, is that there was no significant reduction, obviously smaller numbers, but no significant reduction in preeclampsia, but numerically more, non-significant, increase in neonatal unit admission. And then at the other end, we saw in the very low risk stratum, so the under 1 in 50, that 10% of all preeclampsia occurred in those in the 1 in 50 to 1 in 100 strata. So maybe we could actually prevent some of those cases as well. So we have now Prevent 2, which started recruitment on Monday and has recruited 19 women so far. And that, so very similar, consent and randomization at routine 35 to 36 week scan. They have split PLGF, of course, for the screening, and then comprehensive assessment at baseline. And I'll show you some of the secondary outcomes and how this differs. But I just wanted to point out that our low risk stratum is now less than 1 in 100, which is 65%. So 35% of the population would be offered risk stratified timing of birth. Most of them would be timed birth at 39 and 0 to 2. So we're just having one timed birth now. But very high risk women, although they be offered the same 39 and 0 to 2 timing, should they not require delivery or go into spontaneous labor, they'll have more intensive monitoring. So home daily blood pressure monitoring, in-person weekly BP and research blood, an additional a visit at the 2-week post a recruitment mark for fetal well-being. So a scan. And then we will, of course, be looking at women's perspectives, staff perspectives, cost effectiveness, but we're also going to look at postnatal cardiovascular outcomes at 5 to 6 months, plugging them into the postnatal infrastructure at the Fetal Medicine Foundation. So thank you very much for your attention. I'm happy to take any questions by email or now if there's time. Thank you.